Good morning. Today we'll be talking about inflammatory bowel disease, which is a condition that a lot of people need to know about. Thank you, Dr. Asaolu and Dr. Talabi, for coming on the program with us today. This promises to be an interesting one. If I can kick off with you, Dr. Asaolu, can you tell us what is inflammatory bowel disease? Why do we need to know about it?
Thank you so much for having me. It's always nice to be on your show, Dr. Pamela. So I'm happy also about the topic because it's an evolving condition in the Nigerian populace. A lot of people in the recent times have found out that they have a lot of diagnoses for inflammatory bowel disease, and it's always like, oh, can I live in Nigeria with inflammatory bowel disease? How can I see it? How can I handle it? So it's such a timely topic that can help the average person listening. Inflammatory bowel disease refers to some conditions of the gastrointestinal tract that is characterized by persistent or recurring inflammation of the gut. Now, in layman's term, I'd say it's that inflammatory bowel disease is a condition when there is wall in the wall of the intestine. That is, somebody is fighting somebody. Unfortunately, it is that the body is fighting itself. You know, it's inflamed, persistently angry, persistently at war. That is how inflammatory bowel disease can be explained to somebody on the street. And it is very common in North America. A lot of studies have shown that out of the population, 9.9% of 100,000 people have it. Unfortunately, in Nigeria, we have paucity of data because we always believe in the past, in quotes, that it is not common in Nigeria. Oh, no, it's a condition of the whites, it's a Caucasian thing. But that is not the truth. In my practice, I've had about I'm still gathering the data anyway, so I can't say categorically, but a lot of these cases are coming out, especially in our private hospitals where we have access to adequate and complete diagnosis. So I can say categorically that if I have about 100 patients, I'm going to have like 5 to 8 of them to have IBD. So it is actually common, more than we know. And there is need for us to shed light on it. So once again, inflammatory bowel disease is common in Nigeria, more than it is reported. It happens to people, and a lot of people are worried, they are concerned. Why am I having it? Why am I stooling? Why am I have patients, in my patient's words, Dr. Asaolu, I cannot go out without going out with Imodium. Imagine the life of a young man who cannot go out confidently because they cannot stay in traffic. They will need to go to toilet every time. Imagine being embarrassed. Imagine going to your in-laws' house to go and ask for the daughter's hand in marriage and your stooling starts. So it is common, and it affects the quality of life of people that are suffering from it. So we need more information because there is always war in the wall of the gut.
Now, so can you tell us? Thank you. I think that's really very interesting because, I mean, as I said, so many people have said, oh, it's not common here. Oh, it's something, you know, that doesn't affect us Nigerians. So it's important to know that people are having these symptoms and have just simply not been diagnosed, which is, I think, very important that we find out. So what are the symptoms? How would a person present?
So the symptoms of inflammatory bowel disease varies. It could be, the common things are persistent or frequent watery loose stools. So I ask patients, do you think you are more sensitive than other people? Some people say, no, I've never had a settled gut. I've always had a sensitive stomach. I've always had this. They might have inflammatory bowel disease. Some people actually go further to have blood in their stool. Some people go further to have mucus in their stool. And there's something we call urgency, where they cannot get to the toilet before soiling themselves. So somebody wants to poo, you think, oh, I can control it. You cannot control it because sometimes urgency is actually a symptom of inflammatory bowel disease. We also have people coming with abdominal pain. Some people have weight loss because you've not been the nutrients that the body is supposed to use to benefit the body, that is supposed to make you hard weight, you keep losing it in stools. So these are the symptoms. Of course, there are other things that will associate with that, because if you're losing nutrients, the body needs nutrients for different functions. Some people, because they are stooling too often, they cannot clot very well. They have very thin hair. They look like they are malnourished. Some people have eye problems because they cannot absorb what they need to make the vitamins to be absorbed. So there's a lot of symptoms that I can explain in a clear time by explaining how it happens. And that's why I say what I want people to just take from here, if they are taking anything, is that there is war on the wall of the gut. And because of that, the absorptions that occur normally that moves into the system is impaired. And if there's impairment, other things follow. Nutrients are not getting, the person is tired, the person is lethargic, the person's immunity is also reduced because you don't even have enough to fight. So the symptoms vary actually. And the types of inflammatory bowel disease, the two major types are the ulcerative colitis and the Crohn's disease. They are usually their symptoms are not really different. However, when we look at the person's gut, we have clinical differences that we can note. Okay, so but generally the symptoms can be under the same umbrella of
Dr.
chaos.
Talabi,
yeah.
Dr. Asaolu has spoken about the symptoms. Can you tell us anything more? Do you want to add anything more to this?
Well, I was going to say two things. One is, so there's something I call westernization of the African countries, and which more or less is when we tend to want to look like the white people and do everything they do. We tend to want to eat like them, you know. Yes, at the beginning, we used to think it was just purely ethnicity, but we just said it was the white Jewish man, and a specific Jewish man that used to have UC or Crohn's disease. But things have changed, and the way we eat has changed. And we also know for a fact that when it comes to autoimmune issues, that's when the war occurs in the gut or anywhere in the body. It's because there are always trigger factors. So you have one trigger factor or the other that will cause that to happen, right? So I would say that yes, what Dr. Asaolu says is very correct. We don't hold data in Nigeria or in Africa per se, or in Western Africa. Most of the data you get for UC or for Crohn's disease would be mostly in South Africa, if I'm not mistaken, Dr. Asaolu. When you look at Africa, the best I will tell you about is South Africa.
Yes,
but not, and also you will find there are lots of white people living in South Africa, and that's why you still pinpoint it as towards the white race and not towards the black race per se. So until we start compiling the data itself, then we'll know how frequent and how the incidence of this disease in this part of Africa. She also, I remember a patient that came to me with an ulcer, a skin ulcer. And by that, afterwards, she was like, I stool frequently, but maybe just, sometimes you go to the toilet, so like 3 to 4 times a day. I said, are you sure? She said, sometimes it can be 3, sometimes it can be 4, it can be more. And that made me think that she had something to do with UC or Crohn's disease, right? Because they have this painful skin ulcers as part of the what's the name? And this was not in Nigeria, of course, this was outside the country. I have not seen a skin ulcer of that sort in Nigeria. I don't know why Dr. Asaolu has seen one, right? I've not seen any of those skin ulcers in Nigeria. So I would know how to see it in a white person easily. But in a black person, I'll still have to see the dermatologist. This is for UC or not. So some come with skin irritations, some come with eye problems, as Dr. Asaolu said, some come with cholelithiasis, that's stones in the gallbladder. So they come with me, and it's something that we call post-cholecystectomy syndrome. Is when you've taken out the gallbladder from a patient, and the patient is still stooling. And when you're done, after I'm not going to scope the patient, you know, the patient has UC, like, wow. So the reason for the pain wasn't the gallbladder, it was the colon. So sometimes it does happen that way, right?
So no, I think that's very interesting.
Oh, and something I was going to chip in. Sorry, Dr. Palm. Something I was going to chip in was smoking. I wanted to speak to Dr. Asaolu. How many patients have she seen that smoke and have UC or have Crohn's disease?
Okay, I know that question was going to pop up somehow. I've not actually. I think that yes, some of the patients have, especially the male ones, but most of the patients that I've seen in recent times, especially, is they are females actually. So, like I said, is where it is important to collate this data, and we're working on that. Actually, we've gotten it from Lagoon, where I was working before I moved in recent years. A lot of UC patients, and especially people that even come out with pyoderma gangrenosum, the type of ulcer you were mentioning. I had a woman who was in UK for a long time, and she said, oh, I had a colonoscopy. I didn't bother to get the result. And I'm like, are you sure? The colonoscopy was normal. And I'm like, no, I think you might actually have IBD. And truthfully, she had to now send for the histology report, and it was IBD. But what was her major problem was, she said, oh, my tummy is just sensitive, and she kept having this ulcer, and the ulcer got bigger and bigger. So a lot of them are female, unfortunately, and the male ones I've seen, they hardly smoke. Actually, I have a particular patient that had the word she uses is explosive. He says his poop is explosive. Dr. Asaolu, I have explosive poop. He was a 70-year-old male who knew, we've been managing him for a long time and all that. So he wasn't smoking. And I've also had like 19-year-old males who have not started experience. They are just, so ages where they are not really is not really a smoker like that. So honestly, there's a wide range of age intervals, and also the smoking. Although these days now people are smoking a lot, but female smokers are not so many, and most of them are also not smokers, which is actually in quotes correct with what the literature is saying regarding smoking being protective. So I don't know. Some say smoking is protective of IBD and all that. So you want to say something?
Thank you much. Thank you. I think this is very enlightening. And so it's what you're saying, because I know Dr. Talabi alluded to this, Dr. Asaolu, because people have been asking, what is the cause of this inflammatory bowel disease? Because as you said, many people are coming up now and they talk about having a sensitive stomach. Oh, pepper doesn't agree with me. Oh, F4 doesn't agree with me. Oh, it's the fish. But what you're saying is it might actually be inflammatory bowel disease. And so is there a cause for it?
Thank you very much. Usually the cause there's really no identifiable cause if you put it in a specific term. However, there are risk factors associated with it. And the first risk is a genetic predisposition. There's a tendency that there's some genetics, from DNA that could be related to it. And we have risk factors that are also associated with it. So all of them coming together, the environmental factors, the risk factors, all come together. And people say in recent times, okay, it could be that there's exposure to westernized food. It's also a possibility, but many things are actually related. The risk, the gender, and smoking, alcohol. Some people say smoking. The books say that smoking is actually protective. So it's a multifactorial condition. But what we know is that there is an immune basis. There's a genetic predisposition and there's an immune-mediated response. In order for people to understand better, I tell them that it's like an exaggerated response to sometimes an offending agent. Like, okay, let's assume that there's a mosquito bite on your skin, and the next thing is that you bring a hammer to kill the mosquito on your skin, you get to damage yourself. So there's an exaggeration of immune response. So people that also have tendencies to have auto or exaggerated response to immune, to any insightful agent will actually they can have IBD. Now,
yes, I think
what are the... Please go ahead.
Yeah, because one of the things that people, keep talking about now is this increase in processed food. So, and I think Dr. Talabi also alluded to it earlier. The fact that we keep eating processed food, the more processed food we eat, the more allergens, the more alien things that we're introducing into our system. And that is what is causing the rise of, or should we call it an epidemic of autoimmune conditions globally. So I think that is something that people need to bear in mind, so that if they can go back to the time when, we were eating whole foods, because that's what everybody is prescribing now, is whole foods, natural foods, going back to how we used to eat in the past. Perhaps it's something that could reverse this trend, this alarming trend that we're seeing. But can you tell us, because I know there's some listening and thinking, how can I diagnose of inflammatory bowel disease is? Do I have it? How do I find out? Some doctors could even be listening as well. One or two patients, how can I get it? What do I do?
Thank you very much. If you have the symptoms I've mentioned watery stool. Some people don't even have watery stool. Some people might have constipation, funny enough. Some people might have abdominal pain. I've had patients that they actually don't have watery stools, but their tummy is persistently bloated. Or you have blood in the stool, you have mucoid stools, or urgency, or weight loss, you're not gaining weight, you should go to the hospital. So from the clinical history, there's some investigations that will be done. Some ancillary tests, the blood test, the ESR, we'll see whether there are evidences of inflammation in the blood and in the stool. We talk about stool calprotectin, which is like a non-invasive way to know whether there's inflammation going on in the gut. Although the inflammatory marker calprotectin is not specific to only IBD, because any inflammation can actually cause it. But we know majority of inflammation that is persistent, if you're having cholera or you're having normal gastroenteritis, you don't expect it to last longer than 2 weeks or to continue to be there like 5 times a year or 7 times a year. So if you do the calprotectin, we suspect you have the calprotectin and it's elevated, I have, opportunity to say, oh, we might be doing with IBD. However, the definitive diagnosis is done with an endoscopy, which is a colonoscopy and a gastroscopy, because if it is Crohn's, it might be from the mouth to the anus. That's the Crohn's disease, can occur anywhere along the path. If it is ulcerative colitis, yes, it is in the colon alone. So we do endoscopy for you and we take biopsies. So the fact that you even have a normal colonoscopy, which I was saying my patient from UK had, and she felt ill as well, is not enough. We need to take multiple biopsies from different sites and see evidences of inflammation in that area. Then we'll say you have inflammatory bowel disease. Now we can now have other tests. Dr. Talabi has mentioned extra intestinal manifestations, which include the skin. The skin, like somebody can have ulcers, somebody can have joint pain. So whatever the person is presenting, we want to do tests that can help us to highlight what is the pathology involved. Basically, that is it. So the definitive diagnosis is biopsy of that wall to document the inflammation. Thank you.
Thank you so much. I think that's been very conclusive. We haven't actually gone into the details. I know we don't have much time. But can you just quickly tell us the difference between Crohn's disease and ulcerative colitis? And is there any difference in treatment?
No, really. Basically, they are the major forms of inflammatory bowel disease, although we have other forms which are not as common. So the ulcerative colitis is, like the way name implies, there's ulceration in the colon. So it's limited to the colon usually, and it's continuous. We normally in medicine, we talk in GI medicine, we talk about it as being superficial. So there's a superficial ulcer or erosions that you see. Now, on the other hand, you can have Crohn's disease. Crohn's disease is it can occur from the mouth to the anus, and usually it is not superficial. It extends throughout the whole layers. Okay, so I don't want to go deep into medicines. I don't confuse people, but
no need to be too technical.
Yes, muscularis. So you kind of have it as deep lesions, and that's why we say it causes skip lesions. Okay, so it's like it takes this part and goes down.
It's okay. Just don't need to get too technical because we're talking to lay people. But how about this? Now we only have, you won't believe this. There's now no time left, and I hoped to have Dr. Talabi tell us when surgery might be indicated. So we only have a couple of minutes left to the program. So can you just, in a minute, sort of wrap up some things about treatment so that we can just have a word from Dr. Talabi before we end?
Because we know the way it happens, it's more of hyperimmunity. There's excess immune. So the treatment is also drugs to reduce the immunity. Usually steroids, usually some drugs that are calming. We have some, we call them mesalazine. We can have azathioprine, methotrexate, infliximab. These are drugs to calm this, to war. It's just drugs to say, madam, calm down, stop fighting yourself, just medications in that line, basically. Then there are also other things like diet. You want to do nutritional support. You want to take care of pain. If they have a patient on admission now, bleeding severely, you want to make sure that you replace the blood, whatever the complication you want to treat. And please do not keep that kind of patient for long. If you are a GP or something, and you think you're not winning, escalate care as quickly as possible, because they can have, I've seen a patient die because of severe hypokalemia, a young 23-year-old woman, when I was in training, and we in ICU and all that. So it can be very, very catastrophic sometimes. So escalate care as quickly as possible if you're not winning, or escalate drugs too. Thank you very much.
Thank you very much. Any last words, Dr. Talabi, before we close?
So yeah, so I guess we come in when Dr. Asaolu is tired of giving medications, or when there's a complication of the inflammatory bowel disease. In some cases, they have abscesses. In some cases, they have strictures, that's narrowing of the intestine. In some cases, they have fistulae, which connections between one colon and the other, or one small intestine and the colon, or any other organ that is around it. So most of the time, we also have a good eye with UC in terms of it getting into towards cancer. So we try to more or less resect the part. So we start with colectomies, then we start with pancreatectomy. So say one segment of the colon, then the whole colon, and then we now take the rectum out, and like that. Right, we leave the patient with a pouch using the small intestine per se. Right. In terms of Crohn's disease,
these are in extreme cases, though.
Yeah, that's what I said. Like, when Dr. Asaolu is tired of giving them medication, she passes them over to us. When the medication is not working, she escalates it to us, and then we go with something definite in terms of. But sometimes they come with obstructions. They come with chronic obstructions, and you find there's inflammation all over the colon, and they have this history of diarrhea rather than constipation. Right? Yeah.
So, but the important thing is to notice that if you have something like this, or people are listening have something similar to this, they need to seek help, and to seek help from the right people. So if the GP is not helping, then we need to seek help from a gastroenterologist, and if necessary, a surgeon, if the complications are there. Thank you so much, both of you, for coming to shed light on this very important condition. We really appreciate it.
Thank you.
Let me say that it is important to have yearly surveillance with colonoscopy. If you are diagnosed to have IBD, whether ulcerative, whether Crohn's, you must have colonoscopy every year because of the increased risk of cancer in people with IBD. Thank you.
Thank you. Thank you very much.
Thank you for watching. Please like, share, and subscribe for new video updates.